Hello friends, I am Dr. Manoj Kumar. Welcome all of you in my YouTube channel AdityaClinic. Friends, today I am going to discuss a study which was published 5 years back in Times of India. In that study, it was reveals that osteoarthritis will be the number 1 disease in India and diabetes will be the ranked 4. The most disturbing fact of the research was that in age group of 25 to 35 year, osteoarthritis will be the figuring second most prevalent disease after diabetes. The fact which was published 5 years back in Times of India became realities. You can see in your society that every fifth person is suffering from the osteoarthritis. And there was a very good awareness about the diabetes and the cancer. So people is aware how to prevent them. But there is very less awareness about the osteoarthritis. In this video, you learn how to delay the progression of the osteoarthritis by doing the physical exercise, physiotherapies, balance and nutritional diet. In this video, medical and nursing students can also learn how to give intra-articular injection, and this procedure is defined by the doctor of their fields. Friends, in this video, you will learn about the uses of the sodium hyaluronate injections. It came in a pre-filled syringe given weekly for thrice or fives earlier, but now a single dose is also available in the market. So many companies is marketing this product with a different names. So young age people who are suffering from the osteoarthritis can delay the progression of the osteoarthritis with the use of the sodium hyaluronate injection. In this video, you will see the uses of the sodium hyaluronate injection, how to use sodium hyaluronate injection. If there is edema in the knee, then first doctor will have to aspirate them from the knee, and then the sodium hyaluronate injection is given in the joints. So please go through the videos.
Worldwide, osteoarthritis is the most common joint disorder clinically encountered. 25 to 30% of the people between 45 and 65 years experience symptoms of osteoarthritis, and almost 60% of the people above 65 years show signs of osteoarthritis.
In my practice, the patients whom I usually see suffering from osteoarthritis are from the elderly population, that is after 50 years. These patients usually complain of pain, difficulty in movement or locomotion, stiffness, especially after waking up in the mornings, which improves sometimes with movement, and occasionally they do complain of grating or grinding sensation in the knees.
Osteoarthritis is emerging as a major medical and financial concern as the population ages. For the afflicted individual, it translates into a distressing limitation in movement or activities, often with functional compromise. With the impact on the society equally distressing, leads to increasing economic burden, both in terms of direct medical costs and loss of productivity in younger patients. It is imperative to diagnose osteoarthritis early, recognize complicating factors, and make effective use of available treatment options. The hallmark of osteoarthritis is the irreversible destruction of the articular cartilage in the synovial joints. which can often be caused or aggravated by several factors like increasing age, obesity, repeated trauma to the joints, probable genetic factors, and birth defects in articular cartilages. Biomechanical and biochemical forces play a role in cartilage destruction. The factors implicated often include cytokines, growth factors, interleukin-1, tumor necrosis factor B, and collagenolytic enzymes. At the core of these pathological changes is the role played by hyaluronic acid. Hyaluronic acid is a 50 lakh molecular weight linear polysaccharide serving important functions in the synovial joints like load absorption or elasticity, lubrication or viscosity, and also has anti-inflammatory as well as anti-nociceptive properties.
Hyaluronic acid is a naturally occurring substance which is used in the knee joints for lubrication. It is a viscous material, and when the knees are put through a range of movement, this hyaluronic acid creeps in between the joint surfaces and provides lubrication.
However, dramatic changes in hyaluronic acid is seen in osteoarthritic synovial fluid and include decreased concentration, decreased molecular weight due to degradation and aberrant synoviocyte synthesis, and therefore the role in joint homeostasis is compromised. Thus, in osteoarthritis, the biomechanical and the biological properties imparted to synovial fluid by hyaluronic acid are degraded. It is interesting to know that racehorses with similar degeneration when treated with hyaluronic acid successfully returned to the racetracks. Evidently, the results with humans are no different. The goals of treatment in osteoarthritis have been well defined and aims to provide adequate pain relief, maintain or improve joint mobility, and minimize functional impairment.
So the goals of treatment in the elderly population are pain relief by whatever means, restoration of freedom of movement, and ability to get back to their normal activities as far as possible.
For me, the biggest goal is pain relief, and consequent to that is improvement in the functionality of the patient. And secondary goals, of course, would be correction of deformities, would be reduction of swelling, and improvement of the biomechanics of the joint.
The goals are the joint should be painless, it should not be swollen up, the patient should be able to squat down. That should be the goal of the pain.
The management of osteoarthritis incorporates several treatment modalities and includes non-pharmacological management like patient education, exercises, assisted devices, weight management, and dietary supplements. Pharmacological management like simple analgesics, conventional NSAIDs, COX-2 specific inhibitors, local analgesics, intra-articular steroids, and viscosupplementation. And interventional management like arthroscopic procedures and surgery. The management strategies for osteoarthritis include anti-inflammatory agents, intra-articular corticosteroids, and viscosupplementation. In the step-up approach towards managing osteoarthritis, a clinician would often start in increasing mechanical dysfunction, functional disability, and pain with exercise and education, moving upwards to the use of acetaminophen, then onto intra-articular corticosteroids, anti-inflammatory agents, viscosupplementation, then onto arthroscopy or lavage, and finally onto total knee replacement. NSAIDs have been the mainstay of pharmacological therapy, though there are some advantages for NSAIDs in clinical practice like rapid onset of action, relief of pain and inflammation, and improvement in quality of life. In the long run, they do have several limitations like no effect on disease progression, serious gastrointestinal toxicities, renal toxicities, and hepatotoxicities. Gastrointestinal side effects are the most alarming of all toxicities. According to a CDC press release, NSAIDs are responsible for 2 to 4% life-threatening GI complications per year, 200,000 hospitalizations per year, and 10,000 to 20,000 deaths per year. Selective COX-2 inhibitors are an advancement over the conventional NSAIDs. Intra-articular corticosteroids have been evaluated for the management of osteoarthritis by virtue of their anti-inflammatory properties and are particularly useful in patients with acute exacerbations of pain and effusion because steroids relieve pain, improve muscle function, and what's more, the risk is minimal.
I've had a fairly good experience with intra-articular corticosteroids. I have injected them in those patients who have not responded to my line of conservative treatment with NSAIDs or paracetamol. The duration of pain relief has been fairly short.
However, steroids are often not the final answer to many a patient's condition because of limited, if any, symptomatic relief, flare-up of infections, and corticosteroid arthropathy or joint degeneration is quite common. Intra-articular corticosteroids are often associated with a host of deleterious changes in the joints. They cause decrease in cartilage matrix protein synthesis, nuclear degeneration of chondrocytes, decreased synthesis of proteoglycans, and increased fissures in the cartilage. All these in turn lead to a state of corticosteroid arthropathy. Steroids are also implicated in many systemic toxicities like HPA axis suppression, osteoporosis, hypertension, obesity, and a host of other effects. The stage, therefore, is set for hyaluronic acid supplementation in patients suffering from osteoarthritis. Viscosupplementation with hyaluronic acid has now been in clinical use for more than a decade and has been effectively implemented in various countries across the world. The FDA approval was sanctioned in the year 1997. Viscosupplementation is an attempt to restore the useful properties of hyaluronic acid in the osteoarthritic synovium. Typically, it restores the protective, lubricating, shock-absorbing, and rheologic effects of the synovium.
I think the biggest role is the restoration of some of the viscous properties of the synovial fluid itself.
It is interesting to note that the drug disappears after approximately 10 to 20 hours after an injection, but its effects persist for a longer duration. This is due to the fact that hyaluronic acid exerts a multifaceted action in the osteoarthritic synovium, some of which are long-term effects such as restoration of elastoviscous properties, normalizes synoviocyte synthesis of HA, anti-inflammatory effect, and analgesic effects. Of critical importance in the successful treatment outcome is the technique of intra-articular injection in knee osteoarthritis. The size of the needle should be 22 to 18 gauge, the narrower the better, and the needle length should be 1.5 to 2.5 inches. The patient should be sitting with the knee hanging over the table at 90 degrees and supine with knee flexed or extended. A vent flow has its distinctive advantages like ease in tapping and effusion, less trauma to the synovial membrane and cartilage, and being longer, better suited in obese patients. Hyaluronic acid has to be injected intra-articularly through any of the following approaches: anterior-medial, anterior-lateral, superolateral, or into the patellofemoral joint. The exact placement of the needle in the joint can be confirmed by various techniques like pre-injection of saline or air, aspiration moisture in the syringe, resistance to flow of hyaluronic acid during injection, needle tip palpation of articular cartilage or bone surface, and fluoroscopic injection of contrast material. The maximum potential therapeutic benefits of hyaluronic acid are dependent on accurate intra-articular needle placement.
Then I usually go into the medial joint space. You can feel the medial joint line very easily. You can just feel the edge of the patella and the patella tendon, and then just like we do an arthroscopy portal, for example for an anterior cruciate ligament reconstruction, I go just about 0.5 centimeter below the inferior edge of the patella and 0.5 centimeter lateral, and then direct the needle at about 20 to 25 degrees medially and parallel to the flow with the patient sitting down, and generally that will get you into the knee joint.
Here is Mrs. Falguniben, a 38-year-old young female having osteoarthritis of the patellofemoral joint since last about 2.5 years. She has been suffering from it for quite some time, for which she was initially put on NSAIDs, physiotherapy and all sorts of conservative modalities. Regarding the pre-injection preparation, I always insist on scrubbing all sterile linen to be used, especially for the patient as well as for the trolley, and everything is to be done under aseptic conditions inside an operation theatre. As we are invading a sterile joint, whatever due care should be taken has to be taken. There should not be any compromise, lest any patient may develop a serious infection of the knee at our hands, which is not pardonable at any cost. Hence I always insist on the necessary due aseptic conditions that I have just demonstrated. I would like to emphasize one point, is that after the sterile preparation of the skin, I always infiltrate the skin with xylocaine 2% and not give them together simultaneously, so that the subsequent injection of hyaluronics with a bigger needle would not be so painful. एक इंजेक्शन वाक्स है, This is the most common route utilized by most orthopedic surgeons, the superolateral corner of the patella, to infiltrate or aspirate anything from the knee joint. The other common route that may be utilized is the infromedial side. I always ask the patient to flex the knee and extend it immediately after the injection, so that whatever fluid we have injected, the hyaluronic acid as well as the constituents are thoroughly circulated well within the entire knee joint. I always instruct the patient to mobilize the knee immediately post injection, just to ensure the complete spreading of the fluid entirely around in the knee joint for a few minutes subsequent the injection.
The dosage of hyaluronic acid is based on individual response to treatment. Ideally, a course of 20 mg of hyaluronic acid intra-articular injections given weekly once for 5 weeks is shown to be associated with favorable results. Patients should be advised to avoid weight bearing for 48 hours after injection. As the injection is viscous, it can be usually given under local anesthesia with a large needle. For best results, hyaluronic acid could be given in stages 1, 2 and 3. In stages 4 to 6, hyaluronic acid is still of benefit in the transit time for total knee replacement. The beneficial effects of a course of 5 injections persists for a period of 6 to 12 months. Hyaluronic acid demonstrated favorable benefits in most studies and resulted in statistically significant reconstitution of the superficial amorphous layer of the cartilage, improvement in chondrocyte density and vitality, statistically significant reduction in synovial inflammation, significant increase in synovial repair process, reduction in joint effusion, and significant improvement in pain and joint mobility. Hyaluronic acid provided sustained pain relief and improved patient function. 56% of the patients treated with HA had a 20 mm reduction in the VAS as compared to 41% of placebo-treated patients. At week 26, 47.6% of HA-treated patients were free from pain compared to 33.1% of placebo-treated and 38.9% of naproxen-treated patients. Hyaluronic acid demonstrated potential structure-modifying effects in the cartilage. Progressive chondropathy was only plus 5.1 plus or minus 12.7 in the hyaluronic acid group versus 16.7 plus or minus 18.3 in the placebo group. Hyaluronic acid demonstrated sustained efficacy even at the end of 1 year. Hyaluronic acid demonstrated efficacy in 77% of the patients at the end of 1 year, compared to 54% in the control group. Hyaluronic acid significantly reduced the radiographic progression of the disease. The group treated with hyaluronic acid showed a mean loss of joint space to the tune of minus 0.22 compared to minus 0.60 in the placebo group. And what's more, hyaluronic acid has been found to be extremely well tolerated. There are no systemic reactions reported, and minor localized pain or effusion that resolves within 1 or 2 days are the commonest reported side effects, 3% per injection. There is a possibility of faulty injection procedures causing the local reactions. This remarkably is in contrast to NSAIDs, which are associated with 16,500 deaths per year in the US. In over 10 million injections, no deaths were reported with hyaluronic acid. Hyaluronic acid is also free from the detrimental local and systemic effects of intra-articular corticosteroids. Thus, Viscosupplementation can only benefit and do no harm. It is safe. It is clinically efficacious. It is cost-effective in the long run, and the mode of action is relatively well understood. Viscosupplementation is an attractive alternative to conventional therapies in a wide spectrum of patient population. Patients not responding to standard pharmacological and non-pharmacological therapy. Patients intolerant to any of these therapies. Example, GI problems with NSAIDs. Patients who are not candidates for TKR. Patients unwilling for surgery. Patients with failed surgical procedures, and to delay TKR in younger patients. It is important to remember that viscosupplementation is contraindicated in special circumstances. Bone-on-bone joint space on X-ray with malalignment, synovial effusion with significant particulate debris, sensitivity to the product, and obvious mechanical internal dearrangement.
Mainly a patient having a known hypersensitivity to a foreign protein should not be given these injections, as they contain the rooster combs, which are antigenic in nature. Second thing, any patient having had some sort of reaction following the first injection should be discontinued, and any patient having a local cellulitis or some form of sepsis in and around the knee joint should not be given these injections. One more thing is the synovial effusion. If it is present in a large amount, then it should be tapped to a certain extent, but it should not be, the injection should not be given in the same sitting. Some authors do advocate tapping a synovial effusion and instilling the injection at the same time. However, it has led to a little bit of a complication, in the sense it does induce an increase in the pain on the second and third day, as far as my experience goes, which is why I have stopped doing it.
Thus, the future is indeed bright for hyaluronic acid and for patients with osteoarthritis of the knee. The benefits of hyaluronic acid could be maximized by keeping these in mind. It works best in radiological settings 1, 2 and 3. Effusion must be drained first, followed by hyaluronic acid therapy. In case of loose bodies, arthroscopic lavage needs to be done prior to hyaluronic acid therapy. The use of anesthetic agents minimizes any transient redness or pain. Additional benefits accrue if the first dose of hyaluronic acid is preceded by intra-articular steroid, and conventional oral analgesics could be co-prescribed. Halonix, the hyaluronic acid